Bismillah ar-Rahman ar-Rahim. Today we will continue talking about neoplasia, and our third lecture will have two main topics. The first one is the host defense against tumors, which is called tumor immunity. Now, our cells are replicating every day, and we have continuous mitosis that occurs throughout our body. And definitely through this replication, some errors will happen. And those errors can transform into cancer. Now, how do our immune system, or why don't every mutation or every faulty replication result in cancer production? Because we have an immune system that is capable of detecting such problems that and he can deal with it and prevent development of malignancy. So as we said, we have numerous mutations that occur in individual cells during our life, either during replication, mitosis, or sometimes during any mutagen that we are exposed to, like ultraviolet light or some chemicals that we have talked about in the previous lecture. So why, as we said earlier, we don't have tumors at each mutation that happened or at each faulty replication that occurs? Because we have immune system and immune surveillance that that is always, let's say, awake and keep looking for such mutations and the problems for prevention of development of cancer. So what is the definition of immune surveillance? Now, immune surveillance is the normal immune system that's present to protect against the development of tumors. Such tumors, or certain tumors, they have antigens and they are counter-reacted or counteracted by antibodies in the body. So it's like any foreign material that enters the body. There will be some antigens that are different from the other cells, and those can be detected by antibodies. Now, how did we know that this is true, or this is that the immune system is one of the mechanisms in fighting cancer? Because the patients, when they do not have immunity, they will develop a lot of cancers. For example, patients with congenital immunodeficiency, they have 200 times increased risk of cancer, and also immunosuppressed patients have increased rates of cancers like lymphoma. So this gives us evidence that the immune system is a very important protective measure against cancer development. So what are the parts of the immune system that participate in defense against cancer? So one of the most important components are the cytotoxic T lymphocytes, or CD8 positive T cells. So those cells, they exert their function by recognizing the major histocompatibility complex type 1 associated antigens. They have receptors that are responsible for, let's say, recognizing those antigens. They attach the receptors to these complexes or those antigens, and they induce cytotoxicity, induce apoptosis of that tumor cell. Another part is the natural killer cells. And natural killer cells, they have no need for sensitization, and they are part of the first line of defense. They are part of the innate immunity. They do not have specificity like receptor ligand interaction or antigen antibody interaction. They have certain, let's say, triggers that will trigger their action and result in damage to the destruction and damage of the tumor cells. They complement the action of cytotoxic T lymphocytes. So the tumor cells that cannot be detected or cannot be seen or cannot be damaged by the natural killer cells, which are the first line of defense, they can be damaged by the cytotoxic T lymphocytes. So the natural killer cells are the first line of defense, while the cytotoxic T lymphocytes, let's say, they complement the action of the natural killer cells and vice versa. Also, we have the macrophages, which are usually activated by the cytotoxic T lymphocytes, by releasing interferon gamma from the cytotoxic T lymphocyte and natural killer cells. They will come and engulf these damaged tumor cells. And also in rare or in other cases, we have the humoral immune response, which is the antibody antigen reaction, that the tumor will have a specific antigen that is detected, and antibodies will be released against this antigen, resulting in antigen-antibody interaction, immune system activation, and destruction of the tumor cells. So what are the types of tumor antigens? Tumors share the major histocompatibility complex with the normal cells. So major histocompatibility complex is present on both normal cells and in tumor cells. Also, we have the tumor-specific or tumor-associated antigens. Tumor-specific, which means that they are specific to certain type of tumor. Associated antigens, which means that those can be seen in different, let's say, tumors. Those are maybe helpful in diagnosis and follow-up of some tumors. And we will talk about them in the next few slides. So, what are the specific or the associated tumor antigens? The first type are the products of mutant oncogenes and tumor suppressor genes, like the RAS protein. So some tumors that have certain mutations, usually they have, let's say, production of those mutant genes products in their in the serum or in the blood, so you can detect them. The second type are the mutant proteins induced by chemicals and radiation-induced tumors. So also the mutations that result from certain carcinogens, like the chemicals or the radiation, usually can also be seen within the tumor itself or within the blood of the and released into the blood, so they can be detected. Number 3, overexpressed or aberrantly expressed cellular proteins. So those patients or those types of tumors, usually they produce certain normal type of proteins that are present normally in the body, but due to the presence of the tumor and the excessive production of such proteins, usually they are in high levels and they can be detected, like tyrosinase in melanoma. Also, they have the cancer testis genes like the MAGE1 also in melanoma, and we have the HER2 in breast cancer. So those are overexpressed proteins that are usually seen in normal cells, but in the tumor they will be overexpressed and they can be detected due to their overexpression. Also, we have the tumor antigen that are produced by oncogenic viruses like in human papilloma virus, which are the E6 and the E7, and also in the EBV infection. And those proteins, if you remember, we talked about them. They are, let's say, an integral part in the oncogenic function of the virus, because they attach to tumor suppressor genes, inhibiting their function, resulting in tumorigenesis. Also, we have the oncofetal antigens, like the CEA or the carcinoembryonic antigen that is produced in colonic cancer. And also we have the alpha-fetoprotein, which is produced in liver cancer. So if you are suspecting that this patient is having, let's say, a colon cancer, and you ask for his blood for detection of the CEA, if the CEA is pretty high, then you have this patient will be in a high risk, or your diagnosis will be closer to colonic adenocarcinoma or colon cancer. Same way in liver carcinoma or liver cancer. The alpha-fetoprotein, when it is high, this means that this patient is highly suspected to have liver cancer. Also, we have certain mucins like the MAC1, which is increased in breast cancer, and carcinoma, CA125 and CA19-9, which are in ovarian carcinoma, also increased in ovarian cancer. We have also cell type specific differentiation antigens, like in B-cell lymphoma, we have the CD20. So those tumor specific antigens, as we said, it might be related to the mutation itself, or might be to overexpression of certain genes, or it is a normal part of the cell, which is not a tumor cell, but it will be increased due to proliferation of the tumor. And what's the importance of such antigens? they can be used as tumor markers. And what does tumor markers mean? It means that we can use them to detect cancer and also for follow-up cancer. Like as we said earlier, the carcinoembryonic antigen. The patient was diagnosed to have colon cancer, then he underwent surgery, of which the tumor was removed, and the patient received, let's say, the adjuvant therapy after that, and then we will follow up the patient by imaging and also by tumor markers. So tumor markers, like the carcinoembryonic antigen in case of colonic cancer, we test the patient, let's say after 6 months for CEA. If the CEA is increasing, then this means that the patient is having some recurrence, and we should check the patient thoroughly for recurrence of the tumor. Also, other markers that are seen in other cancers, like the prostate-specific antigen, the PSA, which is usually seen in normal population in many conditions, not only cancer. So if the patient has prostatic cancer and he received therapy, whether surgery or hormonal therapy, and the PSA start rising again, this means that the patient is having recurrence. So those are, let's say, a non-invasive follow-up material for follow-up measures for the patient who has a tumor. So this slide displays how the immune system can detect the aberrations that are seen in tumor cells, so they can prevent the carcinogenesis process. So this is the normal thing that happens usually, that we have normal cell that contains normal self proteins displaying major histocompatibility complex type 1, and such there will be no T cell response against this normal cell, because it has all the criteria for passing the test by the T cells. Now here, this cell, it has the product of oncogene or mutated tumor suppressor genes, which is the first type of, as we said, like the tumor markers or the damage that happened to the cell. We have this, let's say, abnormal material, which is the product of the proto-oncogene or tumor suppressor gene, like mutated RAS or fusion protein or tumor suppressor genes like the mutated p53. So this lesion or this tumor cells can be detected by the CD8 positive cytotoxic T lymphocyte, resulting in destruction of such cell. Another thing that could activate the cytotoxic T lymphocytes is the mutated self protein. When you have various mutant proteins in carcinogens or radiation, induced animal tumors, variation of mutated proteins in melanomas, such mutated self proteins can also activate the cytotoxic T lymphocytes. A third type also is the overexpression of aberrantly expressed self proteins, like the HER2, as we said, or the MYC in melanoma, and such expression of tyrosinase, GP100, MART in melanoma. This also will activate the CD8 positive cytotoxic T lymphocyte, resulting in the destruction of such legionel cell. We have also the product of oncogenic virus, like the HPV virus, which produce E6 and E7 proteins in cervical carcinoma, the IBNA protein in EBV-induced lymphoma. Such products can also activate the cytotoxic T lymphocytes, mainly the virus antigen-specific cytotoxic T lymphocytes, which will also attack this tumor cell, resulting in destruction and elimination of tumor cells. So how do tumor cells escape this immune surveillance process? There are multiple, let's say, measures that the tumor cells can do in order to escape the immune surveillance. First of all, they have selective outgrowth of antigen-negative variants. So as we talked about in the metastasis process, and we have multiple clones within the tumor itself, the same thing here, that there will be selective growth of certain clones that do not express antigens that can be recognized by the tumor cells. So those by the immune cells or by the T lymphocytes. So such clone will expand, proliferate, and form most of the tumor, resulting in growth and development of the tumor. The second process is decrease the major histocompatibility complex molecules on the tumor cell surface, which will hinder the process of attacking by the cytotoxic T lymphocytes. The third thing they can do is immunosuppression. Some tumors, they secrete materials or proteins that decrease the immune system, decrease the efficiency of the immune system of the body in order to prevent the process of immune surveillance. Also, we have a process called antigen masking. Antigen masking means that those cells, they hide the antigens, or they has a process of, let's say, preventing the immune cells from recognizing such antigens by either hiding them inside the tumor cell itself or by certain changes within the antigens. Also, they can do something called downregulation of the co-stimulatory molecules. Co-stimulatory molecules is proteins that are expressed on the surfaces of the cell, which are important for the function of the cytotoxic T lymphocytes and the immune cells in general. So when they downregulate or decrease the expression of such co-stimulatory molecules, the function of the immune cells or the immune surveillance will not go in the usual pathway, resulting in escaping of these cells from the immune surveillance process. So now let's move to the second part of the lecture, which is the clinical aspects of neoplasia. Now, how do the tumor that is growing within the body affects the body or affects the host? We have multiple factors. First of all, the location. Now, location of the tumor, we have the extension on the nearby structures and organs, and also the anatomic pressure. So if the tumor is in the brain, this will be a very dangerous tumor, because any damage to the vital structures within the brain, like let's say in the brain stem, this will result in instantaneous death. Also, if we have a tumor, let's say in the lungs or in certain area that compresses the bronchus and result in malfunction, so it's totally different from a tumor in the muscle or in the soft tissue, because in that area it's not that that important location. Hormone production. So some tumors, they produce hormones. As they produce normal proteins, they can produce also hormones, and the excessive production of certain hormones will result in various syndromes, and those syndromes, as we will see next, is called paraneoplastic syndrome. Para, which means that syndromes that are related to neoplasia. We have also acute symptoms like rupture of the tumor or hemorrhage, infarction by compressing the blood supply of certain organs, intestinal obstruction, like if you have a colon cancer, it can grow until it occluded the lumen of the intestine, result in intestinal obstruction, bleeding, hemorrhage from certain tumors. So any of the above may happen in both benign and malignant tumors. So if we have a benign tumor in the brainstem, it can be lethal and kill the patient. But and the malignant tumor will be also a problem. And all those can happen in benign and malignant tumors. The only thing that occurs only in malignant tumors is the metastasis. Usually, benign tumors do not metastasize, while malignant tumor, they can metastasize into distant sites within the body. One of the syndromes that is associated with cancer is something called cancer cachexia or cancer cachexia. Now, cancer cachexia is a wasting syndrome characterized by loss of body fat and weight, with also muscle loss and marked weakness, anorexia, which is decreased appetite, anemia, and fever. So the patient will have this cocktail of symptoms with the malignant tumor or with the cancer. Now, reduced appetite and food intake, but the patient will have a very high metabolic rate. That's why the patient will start to lose weight, fat, and also muscle. Usually, this is related to the release of cytokines by the tumor cells, which will elevate the metabolic rate, and they will have negative effect on the appetite and the food intake. And also, we have the macrophages, which will produce also tumor necrosis factor, which is one of the cytokines that have an important role in the cancer cachexia syndrome. So, one of the most important events clinically that happens with cancer is the paraneoplastic syndromes. Usually, paraneoplastic syndromes are systemic symptoms that cannot be explained by effects of local or distant spread of tumor or hormones appropriate to tumor tissue. So, like if we have a tumor in the parathyroid gland and it produced parathyroid hormone and the patient will have hypercalcemia, this will not be a paraneoplastic syndrome because this is a simple logical process that the tumor cells will produce parathyroid hormone. This will result in increasing calcium level and hypercalcemia. While if other tumor, likely lung cancer, lung small cell carcinoma, start producing a parathormone-like or a parathyroid hormone-like material that will result in hypercalcemia, this will be a paraneoplastic syndrome. So it's due to ectopic production of hormones from its abnormal sites. It will not be produced from the normal sites of hormones or other factors or some things that can act like hormones. May precede the tumor, like in occult cancer, the patient presents with this syndrome, with the paraneoplastic syndrome. But if the patient will not be diagnosed with cancer, you need to check if the patient has cancer or mimic metastasis. Usually, this syndromes occurs in 10 to 15% those syndromes occur in 10 to 15% of cancers. Now, what are the types of of paraneoplastic syndromes? Sorry, we have the endocrinopathies, which is release of hormones or hormone-like materials from ectopic sites, osseous and articular changes, which is changes that affect the bones and the joints, vascular and hematological changes like anemia, leukopenia, or other hematologic changes, nephrotic syndrome, which is protein losing nephropathy, and protein losing syndrome. The patient will start losing his proteins through the kidney, and many others paraneoplastic syndromes. We will talk about few of them within the next slides. So, what are the paraneoplastic syndromes? The first cancer is small cell carcinoma of the lung, and small cell carcinoma of the lung can produce multiple paraneoplastic syndromes. First of all is Cushing syndrome, and this is due to ectopic production of ACTH, adrenocorticotropic hormone, which you all know that it exerts a stimulatory function on the adrenal gland, resulting in cortisone production or corticosteroids production, let's say, which will result in Cushing syndrome. Also, they can produce ADH, antidiuretic hormone, result in urine retention. Also, they have hypertrophic osteoarthropathy and finger clubbing, which can be associated with small cell carcinoma of the lung. And those mechanisms of development are a little bit complex. Also, they can induce venous thrombosis, which is called Trozier phenomena. This is mainly related to production of certain cytokines or coagulatory materials from the tumor itself, which result in excessive thrombosis and coagulation within the venous in the veins of the body. Venous thrombosis and Cushing syndrome both can happen also in pancreatic cancer and also in other types of cancers. So the paraneoplastic syndromes, some of them are specific for certain types of cancers and some of them are not. They can happen in different types of cancers. This is the finger clubbing. As you can notice, we have like soft tissue swelling and edema at the base of the nails, and this can be clinically detected by physical examination by certain measures. You will talk about it later in the clinical years. This is the hypertrophic osteoarthropathy. You can notice how the ossification happens within areas that usually they are not heavily calcified in the normal in adults. Look, here there is ossification at the knee joint and presence of this hypertrophic ossification within the bone itself. Also, squamous cell carcinoma of the lung, breast cancer, and renal carcinoma, they can produce parathormone-related hormone, which is let's say a chemical that has a very similar structure to the parathyroid hormone and can exert its action on the body, resulting in hypercalcemia. Now, hypercalcemia due to skeletal metastasis is not a paraneoplastic syndrome because it is a, let's say, a process that occurs due to destruction of the bone, not due to bacterial production from the cancer cells like this, the endocrine or a parathormone-like material. So it's due to direct damage of the bone by the metastatic tumor cells. Other examples, the hepatic and renal cancers, they can produce polycythemia due to the production of erythropoietin. And erythropoietin, as you all know, is a, let's say, like a hormone that is that increase the bone marrow production of red blood cells. Advanced cancers can result in non-bacterial thrombotic endocarditis or marantic endocarditis, which is an endocarditis that is sterile with no infectious microorganism due to thrombosis and damage to the endocardium. Now, fibrosarcoma and hepatocellular carcinoma can result in hypoglycemia as a paraneoplastic syndrome due to the production of insulin-like substance, and you know insulin can induce hypoglycemia, and many other examples. Now, up to here, we have finished the third part of the neoplasia part 2, and we left with only one part that will follow in the next few days. Thank you very much.